Good evening, everyone. We welcome you all to OrthoTV online. This is the 4th episode of the Young Surgeons Forum Arthroplasty. We are delighted to have with us none other than Dr. Arun Mullaji, a very well-known figure not only nationally but internationally in the field of knee replacement. To introduce today's topic and speaker, I hand over to the moderators.
Yeah, good evening, one and all. First of all, thank you, Dr. Arun Mullaji, sir, for accepting our invitation and to be the mentor for a very interesting topic for today. So we would want to hear about complex primary TKRs, especially the extra-articular deformities. And with sir's experience, all the tips and tricks is what we're going to discuss. Then we are going to have the usual format of 3 young surgeons presenting their cases, and then we'll follow it up with a discussion. So we would have a discussion on and off during the course of the session as well. Dr. Jay, anything else that you would want to add?
Yeah, we are extremely thrilled to have Sir today with us. Sir, with his vast, with the years he spent doing so many cases, we are sure to learn a lot from this session. So, without wasting further time, I'd call Sir to start this topic presentation. Dr. Arun Mullaji, sir.
Okay, so I'll share my screen. All right, so thank you very much for inviting me today. It's a great pleasure to be with young people and discuss with them in a little more detail. It's not really a formal presentation, so feel free to stop me and challenge, question, debate, criticize, comment, whatever you want. So we're going to talk about a variety of complex primary total knees. And this is basically what I would like to talk to you about, that any surgery on when we're talking about knee replacement involves 3 compromises. So compromise between getting the alignment of your limb and component, getting your joint line obliquity, and your soft tissue releases. So in order to correct all these complex cases, you will have to choose one of these or all of these compromises and how much you intend to emphasize one or the other. And depending on that, your management philosophy will be based. So we'll talk about this as we go along, but remember this, that the alignment, obliquity, and soft tissue release are all very important, because we know alignment is important. We know that the joint line obliquity is also important, because that in turn affects your soft tissue balance. It affects your gait, stability. How much soft tissue release you do will also decide the sort of constraint you need, because there may be some tissues which get released without your intent to release them, and that could have unexpected or unwanted consequences. So let's look at all of this. So that's the X-ray on the right, which shows how we've corrected the deformity. And you can see the alignment has been restored. So let's go to the other point about soft tissue release. So how much soft tissue release should be performed? This is a very important subject, and we'll try and cover that as well.
We can't see your screen, sir. We can just see your. We can't see the presentation.
Why? What's happened? It says you are screen sharing.
I can see it at my end.
We are able to see you, sir.
Yeah. Okay. Okay. Go ahead. No problem.
Okay, so let's first talk about issues regarding alignment as they pertain to severe deformities. You know that in the lesser deformed knees, you can do whatever you want: mechanical alignment, anatomical alignment, kinematic alignment, or any of those variations. So now let's look at this 20-degree deformity. And let's say you are going to do a mechanical alignment, traditional mechanical alignment, where you want to align the components at 90 degrees to the mechanical axis of the femur and tibia. So this is how technically, if you perform the cuts and did no release, this is where your components would be. And it obviously makes sense that in order for your component to get in, you would need to do something on the medial side in order to get that space for it to actually fit in there. So that means in a mechanical alignment, you'll need a considerable amount of effort to get your alignment so that these two lines are more or less parallel. And if the two cut surfaces are parallel and balanced, then you have alignment and balance. But in the process, you may have to do something, either do soft tissue releases or certain other maneuvers in order to achieve all this. And you may therefore compromise with your joint line obliquity. What it was before, here you can see, this is how the joint line was. We don't know what it really was before arthritis occurred. And that's the biggest flaw with kinematic alignment, or with any form of alignment. Nobody knows what the alignment was before arthritis occurred. So anyway, you put these components in, you'll have to do something on the medial side, and you will be able to achieve your objective. Now, in terms of anatomical alignments, a slight variation on a theme. Here, you would probably resect even less on the distal femur because you're putting it in a little bit of valgus. And you would probably resect a little less a little more on the tibia medially. But still, you will need to do a substantial amount of release to get your components balanced and aligned. And what you are going to do to get this is what we are going to see in the rest of the talk. And then you come to the most controversial subject, which is kinematic alignment. Now, in kinematic alignment, you use a calipered method of resecting bone so that the amount of bone that you remove plus the worn out cartilage equals the thickness of the component that you're going to put in. In other words, you're trying to recreate what was there in terms of the bony alignment, in terms of the bony structure before arthritis occurred. So now let's say you did it. If you all agree that these are the cuts you would use, assuming a 3 to 4 millimeter defect on the medial femoral condyle, and assuming that there isn't too much of a change on the tibia, you could somewhat reduce the resection if you want. You now put in your components. In order to get it over here, you are now compromising with the alignment. You will end up with almost 10 to 13 degrees of varus if you left this patient with kinematic alignment. This is in the coronal view. And if you look at it in the flexed 90-degree position, if this is your starting point and you now cut the condyles equally posteriorly as you would do in kinematic alignment, and also the tibia more or less equally medially and laterally, then there's a substantial risk of internally rotating the femoral component to a considerable amount because you do not wish to release on any soft tissues as per the kinematic alignment philosophy. So these are the compromises that I'm trying to illustrate. Now, for small deformities, which they see in the US and in Europe, which is typically either 0, 1, or 5 degrees, very rarely do they have more than 5 degrees. 5 to 10 would be a small percentage, and beyond 10, even smaller. Beyond 15, 20, they rarely see them. But these are our typical deformities. So now, which of these alignments should we pick for treating our sort of cases? So let me show you cases that have been treated in India with these type of deformities and what happens with different types of alignment. So this one was 24 degrees of varus. put in 3 degrees of varus on the tibia and 8 of valgus on the femur. All right. And now look at the progression. So this was classical kinematic alignment. Okay, 3 degrees of varus, just about acceptable. 8 degrees of valgus on the femur, not too bad. Looked quite good on the initial X-ray, and this is what happened. And this required revision. Now look at this one. 20 degrees of deformity, big medial defect, kept in 4 degrees of varus and 6 degrees of valgus on the femur. And of course, the same predictable course, the tibia loosens out, massive deformity, recurring again after surgery, requiring again a revision. Yet another one, looks like a very straightforward medial OA. These were the films. This is the post-op X-rays. Again, not looking terribly bad on the post-op. I'm afraid this is what is available. These were the lateral views done at that time, more oblique than lateral, and the AP is also somewhat rotated. But still, nothing grossly abnormal. But then it starts doing this. Tibia starts lifting, and then when you see this person has a massive extra-articular deformity which nobody had thought about or ignored, and clearly required a revision surgery. So really the question is this kinematic alignment a good idea for our type of bones, for our type of metabolic bone disease, osteomalacia, osteoporosis? So that's something for you to think about. So what I personally do is most of these deformities I would correct with some form of an adjusted mechanical alignment. I don't personally think that these big deformities are a good idea for kinematic alignment. I also believe that constraint is not a good idea, and one should use the soft tissues and ligaments of the patient to provide stability rather than a block of polyethylene in a big box. And you can do that provided you don't release the collateral ligaments. So the key question is, should you release the superficial MCL in a varus deformity and the lateral lateral collateral ligament in a valgus deformity? So we'll come to that again as we tackle both these deformities. And now we're talking about real complex TKRs like these. So the first thing is you've got to figure out, is it intra or extra articular deformity? And obviously you cannot do this without long films. In 2005, we presented a paper which said that you should be using long films. And at that time, very senior people, Dr. Ranawat included, who said you don't need long films. Just use a short film and take an X-ray of the pelvis, and that should suffice. That's not going to work in our patients. And now almost every paper from the West and from Europe, from the US says you have to use long films. So there's no doubt about that, because you will not make out if there's any extra articular deformity without a long film. You also need to check whether the patient is going into a flexion contracture or is hyperextending. Most times hyperextension gets missed because it's not looked for. And of course, there's a third dimension, which is rotation. So very often you have a torsional problem as well. So in both in the femur as well as in the tibia, in the femur, you can have a problem because of previous surgery, fracture, osteotomy. And in the tibia, you need not have any of these, and it is just developmental or constitutional torsion, which we often see in many of our patients. So you've got to be aware of these three planes in which the deformity can occur. Coming to the collateral ligaments, now in a varus deformity, it is very important to understand that collateral ligaments, actually the superficial MCL does not contract. what happens is it's the osteophytes that cause tenting of the ligament. And you need to address the osteophytes and not further damage the collateral ligament. What contracts really are the capsular structures posterior-medially, like the posterior oblique ligament, the oblique popliteal ligament, and the capsule itself. Similarly, in the valgus knee, it's not the lateral collateral ligament that contracts, but it's the arcuate and the popliteofibular ligaments. However, it's important to realize that the opposite collateral ligament may be considerably stretched, and that we will address right at the end. So we published this paper in the Bone and Joint Journal, where we've talked about correcting deformities and techniques to avoid releasing the collateral ligaments in these severe deformities and complex cases. And how do you do that is what we are going to talk in the next few slides. So these are the standard varus knees that you all see and deal with day in and day out. So we recently published in December issue of Bone and Joint Journal a very detailed analysis of our navigation data in nearly 500 cases. And 492 cases, PS knees navigated with varus ranging up to 31 degrees. The aims were to achieve an HKA angle of 0 to 3 degrees of varus, femoral component less than 3 degrees of valgus, tibial component less than 3 degrees of varus in relationship to the mechanical axis of the respective bones, aiming for a mediolateral gap difference in extension and at 90-degree flexion less than 2 millimeters. Of course, it should be throughout the range of motion, but in terms of analysis, it makes sense to have some specific degrees. So therefore, 0 and 90 were chosen, but you can do it at 30, 45, 60, and we have the data for all of these angles. No superficial MCL release was performed, and we did not use any constrained implant. So these were the results. In these 400 odd cases, nearly 500 cases, the mean HKA was 1 degree of varus, but it was from -2 to up to 7 degrees. So in some, we did have an excessive varus. The distal femur typically was cut in about half a degree of varus with a 3-degree posterior slope. The proximal tibia, we resected about 8 millimeters, 8 to 9 millimeters on average, half a degree or so in varus, half to 1 degree, and about 3-degree posterior slope. These are the data from this paper. And we measured with the caliper the resections, medial and lateral resection, and they are shown here in the numbers, medial, lateral, in distally as well as posteriorly. Now, what about the mediolateral gap differences? So these in extension, we were able to achieve between 1 to 2.2 millimeters. And at 90-degree flexion, it was between roughly about 2 millimeters. In some cases, it was more than 2 millimeters, typically more on the lateral side. Of these 500 cases, 10% were aligned and perfectly balanced merely after excising the menisci and cruciate ligaments. No release was performed except the deep MCL in order to excise the medial meniscus. Then, when we went ahead and resected the osteophytes meticulously, medially, laterally, and posteriorly, we were able to, I'm not sure what's happening, and there's so many things on the screen that I can't see my data actually. Yeah, 59% were aligned and balanced once the osteophytes were resected. It's of course important to resect less bone the bigger the deformity, otherwise you wouldn't have a thick enough insert for your cases. So the extension gap balance we normally check with a spacer block. giving varus and valgus stresses and checking the figures on the computer screen. Similarly, the flexion gap we balance by using the femoral size and placement in order to balance and equalize our flexion gap to our extension gap. So this is the final outcome. Here you can see this particular case where you can see the joint is absolutely stable. We removed the arrays in order to be able to demonstrate this. The patella is tracking. You can see stability in all planes. Varus, valgus, inflection, extension, mid-flexion. And this is reflected in the graph that you can see with the yellow lines, 90 degrees down to 0 degrees. You can see the gap medially and laterally. So the difference, mediolateral difference is minimal. So it's nice and stable, and we achieve what we really want to do. And this we measured in all those 500 cases, and I presented the data on that. Now, what if, now, as I said, 10% and 59%. So that leaves about a third where you may still need to do something like, for example, in this case. So if you're not able to balance your knee joint, then the next step, for example, is a reduction osteotomy, as we have done in this case, where we remove the posterior medial flare of the tibia. And this is an animation to show you how by removing that posterior medial corner, you're indirectly doing a release of the medial structures, and that gives you correction. And what we've done was we've shown you this X-ray, and you can see on the X-ray the amount of bone that has been removed. So that helps you to correct without doing a release. So when you do a reduction osteotomy, you can get your alignment back, and we published this paper in Clinical Orthopaedics that 2 millimeters of bone removal will give you about 1 degree of correction. So this is now one method of dealing with it. So the first time we quantified the effect of reduction osteotomy. Now let's say in this particular case, we start off with 31 degrees, and I'm going to show you this patient in a moment, a video. 31 degrees of varus. We've done an osteophyte excision and we brought it down to now, let's say, 12 degrees. After that, we've now done a reduction osteotomy and it comes to 8 degrees of varus. So we are still imbalanced and we are still not perfectly aligned. So what's the next step that you do? So that I will show you now in this video clip. So this is the patient, 30 odd degrees of varus bilaterally. So in flexion, it's perfectly stable, mediolateral stability, but in extension, it is tight. So we do a capsular release. And once you do the posterior medial capsular release, we can now put in a thicker insert. And you can see how stable it is right through the range of motion. And this lady had it done bilaterally, and this is within 48 hours, she's walking with a simple stick, flexing to 90, and those are her X-rays. So no release has been performed of the superficial medial collateral ligament. We only excised the osteophytes, done a reduction osteotomy, and a posterior capsular release. And this is again showing you the final images from navigation of the alignment and the stability throughout the range of motion from 0 to 90 degrees. So it's nice and stable. And in fact, if you don't touch the collateral ligament, you're going to be more stable than ever before, than if you actually release the collateral ligament. The moment you release the collateral ligament, you will then need to accommodate a much larger flexion gap. And often you'll have medial instability because you release the stabilizing structure. So very many years ago, we had published this paper in the Journal of Arthroplasty, where we had done a cadaveric study with navigation, where we actually saw the effect of releasing each structure and what effect it had on the flexion and extension gap. And the more structures you release, especially the deep, the superficial MCL, the bigger your flexion gap is going to get. And then you need more constraint to take care of something that you have created. So this joint was never unstable. There was only bone loss, and you corrected it, you rectified it. So you should not make it more unstable than it was. So the remaining 31% could be aligned and balanced with reduction osteotomy and capsular release. Very, very rarely you need to do anything more. And I'll come to that in a little later when you have severe extra-articular deformity. So many of these varus deformities will have a very significant flexion contracture, 30, 40, 50, or even more degrees. Now in osteoarthritis, we know it's due to the osteophytes. The same thing that happens on the medial side happens posteriorly. So your posterior capsule is stretched over these osteophytes. And the moment you remove these osteophytes, most of the times you will get full correction. You don't really need to do anything much more than that, because now the capsule will return to its original length and will allow full extension. In, of course, rheumatoid cases, it's slightly different because this is due to contracture of the posterior capsule, and you therefore need to release the posterior capsule. And typically you would do it on either side of the midline structures, the neurovascular structures. You do a transverse capsulotomy. You have to be a bit careful on the lateral side because you have the popliteus tendon laterally, and you can either go above or below it. And this is the same patient fully corrected with surgery. Now, as I was saying, in some of these varus deformities, you may have very significant extra-articular component. So that extra-articular component, it would be futile to try and correct it intra-articularly. In other words, by releasing the medial collateral ligament, which is really an innocent bystander. It has no involvement in this deformity, and therefore, why should you release it? So in these cases, what we do is a sliding medial condylar osteotomy, because the problem here is that because of the bowing, the medial epicondyle is more proximal. And all you need to do is to bring it more distal so that you don't need to end up releasing the medial collateral ligament. And once you do that, you fix it with a few screws and that's it. So this is to illustrate the same point. You slide the medial epicondyle distally with the MCL attached to the extent required to get a perfectly rectangular gap, and then you fix it with 2 screws. So this animation shows you exactly how it is done. And this is the image showing you, the fixation with 2 or 3 screws. And this is a patient who has had this medial epicondylar osteotomy. You can see full range of motion. They have a perfectly normal gait. They're able to sit cross-legged. They're able to bend, straighten. They have a normal gait. So all that you've done is restored the intra-articular component, the MCL, to its correct position. And we've published this technique in Clinical Orthopaedics as a method to achieve gap balance in very severe varus knees. So very rarely would you need to do this, extremely rarely. But this is a good tool to have in your armamentarium when you're trying to correct a very major extra-articular deformity like bowing intra-articularly. But when you have something like this, for example, now this is a post-traumatic or a childhood injury, we don't know what exactly, with a significant amount of angulation in the femur. This would be far too much for the osteotomy to handle because the amount it would need to be translated is far greater than you could actually have any bony contact between the femur and the epicondyle. So here you would obviously do an osteotomy in the femur. There are different ways of doing it. There are different ways of fixing it. So this is what we've done. We first nailed it with a locked nail. And then we go ahead and do a total knee, again navigated by a miss the nail technique so that your pins for the arrays don't hit the nail or the screws, and you can get perfect alignment. Both were done at the same sitting. This is an example with a distal femoral deformity. So this is a fairly substantial distal deformity, and the closer you come to the knee joint, the deformity has a greater effect on the deformity. So here you can see the full length film. So here a wedge of bone is removed laterally, a closed wedge osteotomy, plated, and we've used a stem. So the fixation here depends on the anatomy of the femur and what you have available. At that time, we didn't have sleeves available, but a sleeve stem combination would also be a very acceptable one. Because of the trumpet shape of the distal femur canal, you may need a sleeve, or you may need a derotation plate like this. Or if you want, you can always do this in 2 stages. So extra-articular deformities, if they are being corrected either in the femur or tibia, they can be done as a first stage, correct the deformity, and then go another day and do your total knee replacement. If you want and you're sufficiently confident of doing it in 1 stage, then you could attempt it in 1 stage as well. But it's a little more tricky and a little more time consuming. So this is the final alignment of this patient. Now, this is on the tibial side, when you have an angular deformity like this is both varus and flexion angulation. So it's a biplanar deformity. Again, your choice is you could first correct this and then do a total knee at a later stage, or you could do it all at one go. It's extremely challenging to do it at one go because the proximal tibia is very difficult to handle and to hold while you're preparing it. So in these cases, it becomes very challenging, and it may be a good idea to first correct it in the first stage, and then come back another day and do a routine TKR. So it depends on how conversant you are with these techniques and in order to decide. So here you can see the animation which shows you how we do it. So first you do your intra-articular correction. Let's say from 20, it's now down to 10. And the balance 10 you correct at the angulation. And then fix it with a long stem component. So for those who are interested, we have this paper on extra-articular deformity, which we published in the Journal of Arthroplasty, where basically we talk about the same concepts. Either you can correct it intra-articularly or extra-articularly. And in order to decide that, you've got to do a bit of pre-operative planning to see whether you could correct it intra-articularly or whether it will need an extra-articular correction. And then the next decision would be, do you want to do these in 2 stages or in 1 stage? And if you're going to be doing it, whether you're going to fix it with a plate, with a nail, sleeve stem, or any of these methods that you choose, or it could be a plaster, for example, if it's in the tibia. But this is again more a fracture fixation topic. So now let's come to the last part, which would be valgus deformities. So valgus are perhaps one of the most challenging deformities, and you also see these, but to a lesser extent. And it's more challenging because you also have the additional problem of flat feet, which is often present in these patients. You have the problem of a nerve issue with the lateral popliteal nerve or the peroneal nerve, which is at high risk if there's a flexion and valgus contracture, because when you correct that, then the nerve gets stretched. And the third issue that's there in a valgus knee is your patella. Very often there is patella subluxation or frank dislocation. So you've got to take into account some of these additional challenges. Remember again that it's not the lateral collateral ligament which needs to be touched. In fact, you must preserve it. What's contracted is the IT band and the posterolateral capsule and the arcuate and popliteofibular ligaments. And as I said, and we published this in Clinical Orthopaedics, that very often you have persistent hindfoot valgus, which you have to take into account when you're planning your alignment. If you leave these people with severe valgus, with planovalgus feet in a few degrees of valgus at the knee, you're going to have a major problem. These people are going to complain of pain in their feet, as well as they're going to stretch the medial collateral ligament over time and may become unstable if you've used a cruciate retaining type of a knee. So you've got to be very careful, not only with the alignment, but with the implant that you choose. So in valgus knees, we aim for a 0 to 3 degree valgus HKA, unless they have flat feet, in which case we will aim for 0 or even a little couple of degrees of varus alignment. So the femoral component, we would align in 0 to 3 degrees of valgus, the tibia typically at 90 degrees. And again, the same mediolateral gap differences in extension and flexion, about 2 millimeters. We do no lateral collateral ligament release, but in valgus knees, sometimes if the MCL is severely stretched, then we'll use a constrained implant. Now, quite often a valgus knee looks horrendous, but is quite correctable under anesthesia. And these really, you've got to be very careful that you don't make them more unstable on the medial side. So your release on the medial side must be 0. Do not do anything at all on the medial side, because if some of you who navigate, you'll realize that the moment you do something on the medial side, you've got 1 or 2 millimeters more to deal with. So if you have only tightness, I don't know why it's doing this, going back and forth, sorry about that. If you have only tightness in extension, then you just need to release the IT band and the posterolateral capsule. And the moment you do that, you should be able to get your alignment and your balance. There's no need to touch the lateral collateral ligament. But if it stays tight laterally in extension, then we do a lateral sliding osteotomy. So here you can see the animation which shows it to you. You slide it distally just enough to get your rectangular gap and then fix it with 2 screws. So to illustrate this, you see this lady with very severe valgus on both sides. You can see on the X-ray that the lateral femoral condyle is hypoplastic distally, and the lateral epicondyle is more proximal. So in order to correct this, either you will have to release the lateral collateral ligament, use a constrained implant, or distally shift the lateral epicondyle. And the moment you bring it distally, you can get by with a PS implant. You have not touched the lateral collateral because you brought it down with its attachment on the epicondyle. So the ligament is absolutely perfectly intact, and the moment the epicondyle heals, which it will because it's cancellous bone, you are back to a perfectly stable and untouched lateral collateral ligament. So this patient will have phenomenal stability. And this again, we've described the technique in the Journal of Arthroplasty for those who are interested. And this is a video clip to show you how we do it. So this was a 15-degree valgus deformity, which is correcting to only 5 degrees. It was well balanced in flexion. So this is how we do our lateral epicondyle or osteotomy, and then shift it distally, and then fix it with a couple of screws. So now you'll have this phenomenal stability right through the range of motion. And the patient will be extremely stable and confident walking and mobilizing. And these are the X-rays. And you see this is at 1 month. This was 4 years ago. Her right knee, you can see she's limping on it. And just about 3 weeks ago, we did her right knee, which was 4 years post-op for the left one. And you can see the range of motion that she has, very comfortable walking with complete stability. Now, if both the gaps are tight in flexion and extension, then you need to release the popliteofibular ligament and the arcuate ligament. In other words, the posterior lateral corner needs to be released. And the moment you do that, you should get your alignment. And sometimes you have a very, very worn out lateral condyle, which is worn out not only distally, but also posteriorly. And these people often have a very severe flexion contracture. We used to see these moribund patients lying in bed with severe flexion due to keeping their knees over pillows. And in these people, either you use a constrained implant, which is one possibility because they're elderly, low demand, so you can surely do that. Or we do the sliding osteotomy, where not only do we slide it distally, but also posteriorly. So both your extension and flexion gaps are perfectly balanced. Like in this particular patient, you can see how she's been lying in bed for many months or years, severe flexion contracture, valgus. And these are people who will be at a high risk for getting a foot drop post-op. So you've got to be very careful when you do your release. Make sure you don't overstretch them. Let them stretch out gradually over a period of time once the anesthesia wears out. Don't try and achieve everything on table. We've had a few cases of foot drop. Fortunately, most of them recover, but it's not a pleasant thing to have post-op. So here you can see that hypoplastic condyle, and we've done this posterior and distal sliding of the epicondyle. That brings us to the last problem, which is severe hyperextension. So the key in hyperextension is to make sure that there is no neurological deficit. So you've got to do a thorough examination of the spine. Make sure this patient doesn't have some spinal pathology. Sometimes it's severe canal stenosis. It could be any other neurological condition where they have severe weakness of the quads, and they tend to lock the knee by hyperextending the knee, by pushing backwards, because the quads are very weak. So you've got to be very careful in these patients. And we have published the technique of how to correct these problems in one of the largest series published in the JBJS. This is a typical one, 14 degrees of extension, 7 degrees of valgus. So it's important to resect less bone both on the tibia as well as on the femur. Here we are checking the extension gap. And after checking the extension gap, make sure you resect very little on the femur, typically 5 or 6 millimeters. And then the placement of your femoral component is also going to be important. Sometimes you may need to go down by one size. You may need to make sure that you're not, you need to distalize it a bit, but certainly take off less bone distally. And posteriorly, you may need to take more because you have the ability then to put in a thicker insert so that you can now balance your extension gap. So this is that patient at the end of surgery. You can see as we do flexion and extension right through the range of motion, tremendous stability. That's how the leg is nice and stable at the end. And this is an example of a combination of valgus and hyperextension. So on the left side, she's already had a total knee, which is actually buckling because of this severe deformity. And she has some soft tissue problem as well, which makes it look even more grotesque. So this is valgus and hyperextension. This is a follow-up at 4 years. So we've again done a lateral sliding osteotomy. There's a large defect and she's obese. So we put in a stem extension. And at 4 years, you can see the correction is maintained. The osteotomy is healed very well. So the key really is to achieve stability with the minimum of constraint, especially the younger the patient, the less constraint you should use. I don't use CR knees because my philosophy is that either the two cruciates work together or you get rid of both of them. So in U knees, you keep both of them, but in total knees, you get rid of both of them. So it's important to get your alignment right. That's the most important. Balance your gaps, use your component size and placement, and then only then use constraint as the last resort. So when would you use more constraint or a hinge? So typically, if your lateral collateral ligament is stretched or the medial collateral ligament is stretched in a valgus knee, so like in this particular example, there's severe stretching, bone loss. So here we'll use sleeves and stems for the bone loss, and the large flexion gap we would take care of by using a little more constrained implant. But we very rarely used constrained in varus knees over the years. In valgus knees, it may sometimes be required, like in this particular patient with a very severe valgus deformity. So here we've used a TC3. And again, in the last 150, we've checked our numbers. We've just used 5 constrained implants in the last 150 consecutive valgus knees. And hinges we would reserve for polio. We still see some of these patients coming and neuropathic joints. So this would obviously require a hinge. So in summary, most of these severe deformities and complex cases you can correct without collateral ligament release. Thereby you can preserve stability and you don't need constrained designs. Extra-articular deformity may require adjuvant procedures, and I've shown you several procedures, sliding osteotomies or closed wedge osteotomies. And very rarely do you need constrained or hinged designs for most of these complex cases. So with that, I'll stop sharing screen and then maybe we can go to some queries that you may have.
Great. Thank you, sir. It was quite a lucid presentation, I must say. So regarding a few points, when would you use an all poly insert? I mean, would you conjuncture to use all poly insert, especially in varus more than 15 degrees or 20 degrees in severe deformities? Was the implant choice the reason for the failure in the first few slides that you showed?
Yeah, I think I showed you some slides where they were both metal back as well as all poly. So I showed you each of them. There were in fact only one all poly and the others.
Yes, that's right. That's right.
3 of them were, I think, metal back and one was all poly. So I would say I don't think the all poly component actually contributes to the problem. It's basically the fact that there is a deficiency of bone on the medial side. The bone is not as strong and you've not balanced the ligaments. You've left it in a little bit of varus. So this pounding occurs on the medial side.
That's right.
Yeah.
That's right.
That leads to microfractures of the trabeculae. And with those microfractures, you have gradual settling of the component. Whether it is metal back or all poly, the same effect will occur if you had the same combination of bone quality, soft imbalance, and malalignment. So and if you had an obese patient, typically female with osteomalacia, that adds to the problem.
Perfect.
So that's the perfect recipe for disaster: short, fat female, osteoporotic, osteomalacic, low on vitamin D, staying indoors. And then you put in a component which is in a bit of varus, the overall alignment is in varus, and your ligaments are not balanced. So every time she walks, she's pounding the medial side of the tibia. And as she does that, it's going to fail, whether it's all poly or metal back, doesn't matter.
So The other question is regarding the medial epicondylar osteotomy. I guess you must be the forerunners of medial condylar osteotomy, at least in this part of India. But if we are comparing medial epicondylar osteotomies compared to the lateral one, the lateral epicondyle is not as unique. It has a lot of attachments close to the lateral collateral as well. So you have the arcuate ligament, popliteus ligament that are just close to your LCL or the lateral epicondyle on the femur. So what precautions would you take while you're doing the slide on the lateral side as compared to the medial side? How do you protect the posterolateral corner of the knee joint?
Basically, I don't think it's, both the structures you mentioned are nowhere near the lateral epicondyle.
Right. Okay.
You're pretty safe. You need to angle it slightly laterally and upwards so that when you put in your screws, they will be at right angles to your osteotomy and they will miss the box. If you're using a box, you need to miss the box. So you need to angle the screws upwards and medially.
That's right.
So make sure your osteotomy is not perfectly vertical, but slightly angled laterally and upwards.
Right.
So that's the only key thing to be aware of. But intrinsically, it's fairly safe. So you can keep a couple of Homan retractors to protect your collateral ligament and your and the tibial bone. But the ligaments are really not at risk.
Close to the. So then, at what stage would you be doing that? So we have prepared, we are navigating your knees. At what stage would you do the osteotomy typically? As we have seen it, you have placed in the components, you do the osteotomy, place in the insert, allow the epicondyle to distalize, and then you're fixing it up. So it's basically at what stage would you do it? Would you still try for a release? When would you stop your soft tissue release? And when will you go ahead with an epicondylar osteotomy?
So my thinking is very simple. Once I've got the menisci and cruciates out, I see how much correction I've got and how much balance I've got. That gives me a sense, do I need to do anything more? Most of the time, you need to remove the osteophytes. You now remove the osteophytes, and again, you assess your stability in flexion and extension. Once you do that, then you decide, is it still too tight? Then you go ahead and do a reduction osteotomy or a posterior capsular release. At that point, if you're still in varus and it's still too tight medially, then you have two choices. Either you release the superficial MCL like your traditional Ransal maneuver and strip everything and strip everything off.
Go around,
medial tibia. I haven't done that for the last 10, 15 years almost now. You just don't touch it. Our exposure on the medial side of the tibia is about half an inch. We are just not doing anything distally. We are preserving that entire envelope as carefully as we can. So at that point, you have to decide, do you believe that you need to pie crust, you need to release something or the other, either the semimembranosus or the superficial MCL, or as I would do, the only likelihood that it's not correcting is that there's an extra-articular component. Any intra-articular component by now would be corrected.
That's right.
This means that there is an extra-articular component, which you should have predicted beforehand. And you should have anticipated that this has a severe bow on the femur. I might need to do this. So you are already prepared. So in fact, when I walk into the theater, I see the x-rays, do all the planning. I tell them, okay, we might do an osteotomy. So that decision is taken beforehand. You should be able to anticipate that there's an extra-articular deformity and plan for it. Or if it's a very angular deformity, you might have to plan your closed wedge osteotomy also with a plate, screw, nail, whatever. These are decisions which are done on planning. It cannot be done intraoperatively. So the more complex the case, the more the planning needs to be done beforehand, not during surgery. The surgery is just an execution of your plan. The entire surgery should be in your mind. I'm going to do this. And now I'm just going to execute those steps. So you should be fairly aware of what to expect. But of course, that comes over a period of time as you get more and more experience. But the important thing is to plan it and start measuring things. Unless you measure, you wouldn't know anything. And the only reason why orthopedic surgeons and arthroplastic surgeons worldwide, keep discussing what is the alignment and what is the best method of treating a total knee replacement after 40, 50 years of this implant being designed, we still have no answers because nobody was measuring anything. That was the problem. Everyone said, this is my method, this is my method, this is how I do it. And nobody had any data to show that, okay, you did this and what did you find? What were your results? What stability did you achieve? What alignment did you achieve? People were not even measuring full-length X-rays. Even today, the Oxford group does not measure full-length X-rays. Now, how much more, primitive can we be as orthopedic surgeons? We're not even measuring full-length X-rays. How many surgeons measure the alignment on a full-length X-ray post-op? How many people? To see what alignment you achieved. Very few people do that. Very few people do it pre-operatively. Forget post-op. So you got to measure. Unless you measure everything, you will not know what you're doing. And all our data is collected only because we measured. All our papers were written because we measured stuff. Measure and analyze it. That's where you start coming out with some data, with some suggestions, and then you can say, okay, this requires this. Otherwise, it's like religion, I believe, I think, in my experience. It doesn't work. If you're speaking in an overseas meeting, you need to publish or you need to present data, facts, hard facts. I did this, found this happened.
That's right. Okay.
Good evening, sir. I have a question for you.
Yeah, go ahead.
Yeah. Sir, in valgus knees with severe deformity, since you have been doing so many surgeries navigated, what is the distal femoral valgus angle which you find to cut based on the measurements, sir? Sometimes in manual, they have been advocating lesser cut than the 5 degrees, which is very conventional most of the times. So generally, what I understand in valgus knees, the lateral compartment is tight. And when you take a lesser cut, actually, we are not helping with the tightness on the lateral side. So with your experience in the navigated surgery in so many valgus knees, what is the range of distal femoral valgus angle do we get generally, sir?
Okay, so we published this again. Everything, if you measure, then you can give answers to everything.
Yeah.
So we looked at our patients and what was it's called the valgus correction angle, VC.
Yeah, distal femoral valgus correction angle.
Yeah, so the valgus correction angle can vary from 2 degrees to 11 degrees.
Yeah.
Okay, so it is massive, the range. Now in valgus knees, we found a bimodal distribution. So in roughly half of them, you will find that the valgus correction angle is 2, 3, 4 degrees.
Okay.
And in another group, you'll find is bimodal distributions around 6 degrees. So 5, 6, 7 degrees. So you have one group which is around 2, 3, 4 degrees and the other one which is around 5, 6, 7 degrees.
Okay.
Obviously, if the 2, 3 degree people you're going to put at 7 degrees or 5 degrees or 6 degrees of valgus, you're going to have a problem.
Yeah.
And the other ones also, you need to cut at the appropriate angle, provided you're looking at a mechanical axis.
Yeah, mechanical
alignment. If you are now talking about anatomical alignment, then you can keep the femur in valgus because that will help your cause. But what will then happen is then you have to make a corresponding varus cut on the tibia.
Yeah.
The moment you do a varus cut on the tibia, you're only going to make your valgus worse.
That's right. Mm.
Okay. So therefore, the valgus knees are neither amenable to kinematic alignment, nor are they amenable to anatomical alignment. So you're going to have to do an adjusted type of alignment, where you take a little bit of this and a little bit of this. So that is where most of the compromises come. So either you compromise on alignment, you compromise on joint line, or you compromise on soft tissue release. If you do release, then you have to put in constraint. You may require constraint. You understand? So if you are releasing the LCL, you're going to have to put in a more constrained implant. You cannot cut off the LCL and say, okay, now it'll be stable, because in flexion it's going to be highly unstable. All those books and chapters where they show that you release the LCL, these people end up with massive flexion instability. Okay, so you'll have to decide. You measure it first, and then you'll have to decide which option is the worst, which is the worst of or the least of the devils, okay, of the three. So what we do is we look at the hind foot. If the hind foot is in severe valgus, then this person I want to get into a neutral position, more closer to 180. I don't want them staying in valgus, because these people are not going to be happy people. They'll complain of ankle pain, foot pain, medial side pain on the knee, because their collateral is going on getting stretched over a period of time, because the weight bearing axis is not through the center but more lateral because of the valgus. So therefore, in these people, you will have to do these releases. And therefore, if the epicondyle is hypoplastic, the easiest solution is bring it down. Straightforward solution, and fix it. That way you've done no release, you've corrected your alignment, and that's it.
Sir, question. You said that you plan when you plan your surgeries, you know whether you're going to do a medial slide osteotomy or not for a particular patient. So when you have these patients with slight femoral bowing, is there a particular angle that you want to see when you say that, okay, now I'm going to do a medial slide for this, or I'm going to do my the routine releases only?
Yeah, so by and large, if you're looking at something like a VCA of 9 degrees, 10 degrees, 11, 12 degrees, these are the ones where you'll have to start getting prepared for doing your osteotomy, because or you risk leaving them in 4 or 5 degrees of varus. So if you are comfortable leaving them in 4 or 5 degrees of varus, then you don't need a slide. So that's the answer.
So what is your post-operative protocol in these cases of slides? What would you normally do immediately post-op?
It's medial
and lateral. What would be the difference?
So for both, we put them in a brace for 2 weeks, long leg knee brace for 2 weeks. They're allowed full weight bearing with a walker, and no knee flexion for 2 weeks. After 2 weeks, we see them, the wound is healed. Then I assess them out of brace. They're fairly comfortable. They are flexing nicely. Then I tell them, now you can get rid of the brace. Usually in 2 or 3 weeks time, this is already fairly gummy, because it's nice cancellous bone, large surface area, compressed, 90 degrees of compression. If you feel the bone quality is not that great, you can wait for another 2 weeks also. Repeat your X-ray at 4 weeks. Make sure the osteotomy is healed and then start knee flexion. None of these people will lose range of motion. They will never get stiff. They will always have fantastic flexion and extension. So that's never a concern that they'll become stiff. So if you wish to protect your osteotomy, if the bone is very soft, or the patient is unreliable, or doesn't understand, or you were not very happy with the fixation and the screw was bone was porotic, then you can keep it for 2 weeks more, 4 weeks more, it doesn't matter. Just protect them till it heals. The valgus ones are not at risk, because your medial collateral ligament is what's taking the load. If you have aligned your knee perfectly well, then the lateral side is not really at risk. The medial epicondyle may need a little more protection. So typically in a medial epicondyle also, you're not terribly worried, because I tend to leave my varus knee in a little bit of varus. So therefore, really there is no avulsion.
No stress on.
Yes, so it is actually protected. So I'm not terribly worried allowing them to weight bear either.
Sir, in various knees, the sequence of release, like taking out the menisci and cruciate, as you said, followed by posterior release, posteromedial release, and reduction osteotomy, followed by, is it the pie crusting of MCL or the medial epicondylar osteotomy? And
So pie crusting was first described by Johann Bellemons. Johann Bellemons is a very good friend of mine, and he actually described it for tight arthroscopies. When he was doing arthroscopies and found the scope was not going in, he took a needle and punctured the MCL in order to get his scope in. All right.
Yeah.
He then extended that because he's more into sports also. He also does arthroscopy and knees, arthroplasty. So then he extended the concept and started needling the MCL for what he thought were tight knees. So we are both members of the Knee Society, and in one of these Knee Society meetings, I had a long discussion with him. And what I told him was that the MCL, the superficial MCL, works across flexion and extension. If you are trying to correct an extension problem by doing needling or pie crusting, you are elongating the MCL in flexion as well.
Yeah.
Right? Which you don't want. So
Actually,
it's an unwanted effect in flexion. So in my personal opinion, it should not be done, because very rarely is there a need for the MCL does not really contract. So firstly, the concept is flawed that you should be doing a needling or a pie crusting. You do it of a structure which has contracted. Show me any proof or evidence that the MCL has contracted and therefore requires pie crusting. There is no evidence at all anywhere in the literature or clinical or surgical data to show that the MCL is shorter.
yeah.
So why would you want to lengthen it? So you are taking a perfectly normal structure and elongating it. For what purpose? You are therefore creating instability.
Okay.
Right. So therefore, in my book, needling and pie crusting are not to be done. Secondly, if you have ever dissected the MCL in our patients, you will see it is 6 to 7 millimeter wide.
Yeah.
It's not like a big, thick, fat band. Okay. It's a very narrow structure. Now you take the tip of your stab knife and start poking holes in it. And there are enough papers, Michael Menegini and various other people, Lieberman's paper, which says that you have a high risk of completely transecting that MCL, because people are doing it just blindly. Nobody is dissecting it out and checking medial and lateral, anterior and posterior border of the MCL. They're just nicking it.
Yeah.
There is a very high risk, and there are enough papers which show that you can create ruptures of the MCL, and suddenly, pack, it's going to open up. And then you'll say, okay, get me TC3, get me hinge.
Yeah.
So it's a bad idea. It's a flawed concept. There is no rationale for MCL pie crusting, but that's my opinion. But it's also based on fact that the MCL does not contract. So therefore, it is incorrect to lengthen something that was never contracted.
So, sir, after all the reduction osteotomy and everything, if the knee is still tight in extension and in flexion medially, then also there is no pie crusting. So then you will do with medial epicondylar osteotomy.
I would first do a release. I would then see whether the reduction osteotomy needs to be redone, whether you can take off a little more.
Yeah.
If not, then there is clearly an extra-articular component.
Sir, how would you decide whether to redo the reduction osteotomy? How much you have to go ahead? Means you have made 4 to 3, then 3 to 2.
Yeah, you will still get 1 or 2 degrees of correction. You can still take off a little more bone, but provided you have compatibility between your femur and the tibia.
Sure.
The sizing has to match depending on which system you use. So like in an attune, you can go up 2 sizes, but in a PFC sigma, you can go up only 1 size.
One size.
So that is very important to be aware of that, because you don't want a 4 on the femur and a 2 on the tibia if your system doesn't allow it.
Yeah.
Yeah. So therefore, there'll be a limit to it. So the key question will be, why are you not being able to balance the knee?
Right.
Right. The knee before it had arthritis was balanced, we presume.
Yeah.
What all has changed within the knee to make it so imbalanced that after removing the osteophytes and whatever capsular contracture has been released, it is still imbalanced. So there is some problem there.
Right.
That problem has to be addressed. It cannot be within the joint. It has to be outside the joint, because whatever was in the joint, you have released.
Correct.
Whatever was at fault. I don't include the superficial MCL as being at fault.
Yeah.
Yeah. The osteophyte is there. You've taken it out. If there's a reactive posterior-medial hypertrophy of the tibia, so that you do a reduction osteotomy.
Yeah.
All right. So that is the next thing you can do. And then you do your posterior capsular release, because that has contracted. So you've now addressed all the pathology. Once you address the pathology, there is no reason for you not to have a balanced knee.
Okay. Right.
Now there's a question from Dr. Dhar, a very appropriate question about CS versus PS, CR or cruciate substituting or cruciate sparing knee versus PS. Why do I use a PS and not a cruciate substituting cruciate sparing knee? So the reason I don't keep the PCL is because we've published our own study where we had looked at histology and immunohistochemistry of the PCL and ACL in arthritic knees. It's published in the Journal of Arthroplasty many years ago, where we looked at the immunohistochemistry, looked for the receptors in the PCL, and beyond about 10 degrees of varus or valgus deformity, there are changes that occur in the PCL, both at the microscopic level and in terms of the receptors as well. So this we published in the Journal of Arthroplasty many years ago with a classification of the changes that occur in these ligaments. So my own personal preference is not to rely on a ligament which itself may be damaged beyond 10 degrees of deformity. So therefore, I believe that you substitute it so that you don't have a long-term risk of instability coming from the fact that your PCL is now elongated, and then you see in some of these patients that they get synovitis, instability. So that's my main reason. And secondly, in terms of physiology, the crossbar linkage occurs when both the cruciates are functional. If you have detached one cruciate, to expect the other to function is a little difficult. I used to do cruciate sparing knees in the beginning, and I found that I was tending to release more and more of the PCL in order to balance it, in order to get adequate flexion. So I stopped doing it, and as a routine, we do PS knees. But yes, there are equally good results from the registry data with CR knees. But remember that the CR knees are typically done in the West, in Australia, in Europe, in America, where people have 5, 7, 8 degrees of varus. Very rarely do you have 15, 20 degrees of varus. So unless the registry data can isolate big deformities from the lesser deformities and then say, okay, for even the big deformities, cruciate sparing knees do equally well, then I'm happy for you to do them, or I'll start doing them. But till I see that sort of data, I will not just accept it, because we know that their population is different from the population we see. Many of them have 3 and 4 and 5 degrees of varus. I remember in one current concepts in joint replacement that I was in the faculty of, they were doing a live surgery where there was no loss of cartilage. That fellow was trying to demonstrate one of those knees, conformist knees, or one of those custom-made implants where he had to take a burr and remove the cartilage in order to put the implant because it was just not working otherwise. So most of these people have some minimal arthritis. And in those people, your ligaments are perfectly intact. So by all means, do a cruciate sparing knee. No problem. But I'm very hesitant with the data that we have done, what we published, that the PCL does undergo changes as the deformity increases. So I would not want to take that risk.
Right. So for want of time, we'll continue the discussions as the presentations go by.
Yeah.
We'll have our presenters present their cases. I'll call upon Dr. Gaurav to present his case first.
Hi sir, good evening. So I'll be sharing my screen. So I'm Dr. Gaurav Kanade. I'm orthoplasty surgeon from the Navi Mumbai. Hello.
Yeah, we can hear you. Go on.
So this is my case. We have one 61-year female homemaker. This was done in earlier my career. So she came to me with bilateral knee pain. She denies of any radiating pain or any claudication pain. So on examination, there are bilateral flexion deformity of around 5 degree with the varus around 10 degree. Spine examination was almost normal. So this was the X-ray. She came to me. So as it was in my earlier career, so the limb, this type of X-ray, I was on cloud 9. And after suggesting her the knee replacement, she got converted to do it from me. So that was a good thing for me. So I convinced her for the TKR, bilateral knee replacement. Then she got admitted also in the hospital. I went again in the evening rounds to take the history again. Then she gave me the history of some childhood trauma to the left femur, which was treated conservatively. So I got it on the scanogram. We shown the malunited around midshaft femoral fracture. This is the lateral. Of the left side, which is around 1 centimeter. The pelvis is tilted. So there is a varus deformity in midshaft of the femur, also the flexion deformity.
Okay, so what are your questions now? So how did you go about planning it? Yeah, that's good.
Yeah. So I planned it. I measured the angle. As it was the varus deformity of the femur, the lateral distal femoral angle was more. It was not around 87 to 90. It was more. So that was I was about to ask to what the next is the scanogram. Only scanogram is better. How do we proceed? And in earlier of my career, I was not doing the scanogram. After this, doing it regularly. It is to calculate the or any correction. Do any planning. Should I go for any corrective osteotomy in the femur or directly go for the plain TKR? If as there is deformity in the femur, the intramedullary rod is not going to go. So what tools which can I use? Any navigation? There was no access to any navigation or robot. So what can I do?
Yeah, so all very good questions. So in order to proceed, you have to measure. You cannot say it is not 87, but how much it is you have to measure. The MLDFA or ALDFA, what is the MPTA angle? So here not only is the femur, but also the tibia. I think MPTA is about 83, 84. I'm just estimating it from here. And the MLDFA angle is also pretty skewed. you can see that the distal femur is in probably about 5 degrees of varus, and the proximal tibia is about 5 or 6 degrees of varus. So what is your final HK angle? It's close to around 15, I think, 15 or 20 degrees.
Yeah.
How much?
So it was around 14 degrees, but actually there is deformity also. So while doing the TKR, we consider that also means there can be some rotation of the condyles. While placing the components, do we consider the...
I am just measuring the angle on the screen. I have a goniometer handy and it is only 30 degrees. Your overall HK is 30 degrees. Yeah. Just for your information, I have this in my hand, the goniometer, and I'm just placing it on your lines and it's about 30 degrees.
Okay.
So it's a substantial deformity. So your choices here are basically whether you want to correct the extra-articular deformity first, because then it simplifies your total knee replacement. So either you correct it first, or you decide, no, you're going to ignore it and see whether you can correct it in surgery. So this is possible. You may be able to get away with it, because if we draw the angle at 90 degrees to the mechanical axis, it's not going to damage the lateral collateral ligament. You're going to have a substantial lateral gap to fill. So you will have to do, in this case, a medial reduction osteotomy. If you're trying to do an intra-articular correction, I think it's going to be extremely, extremely difficult because of the severity of deformity. So here in this case, you have two options, either to do an extra-articular correction at the site of deformity or do a sliding osteotomy in order to correct your alignment and balance. These are the two options that I would consider. If the patient is very elderly and you're not terribly worried, the easiest solution is to put in a hinge or a TC3. But that is not something I would do preliminarily, not primarily.
So what is your experience about using eye-assist or ortholine and the so-called handheld navigations?
Yeah, so I mean, it's great to use tools if you have been using them on a regular basis, but suddenly to use it in a very complex knee where you have not used it on a routine basis may sometimes be more challenging. So if you're familiar with these, yes, it will help you. Otherwise, many of these systems do have extra-articular alignment jigs. So you don't have an intramedullary rod, but you have an extramedullary jig. The other thing you can always do is get an X-ray on table. There is nothing stopping you from having a C-arm or an X-ray and checking your cuts and your alignment. There's nothing stopping you from having a C-arm. Yeah. If you're doing trauma surgery, so you can always check what alignment you're getting. You don't have to accept everything that happens on table. So here you have two choices. I think the deformity is 30 degrees as I measured it. It's substantially extra-articular. It may not be very easy to just do a pure intra-articular correction. You will either have to do a sliding osteotomy or an extra-articular closed wedge or a corrective osteotomy at the site of the malunion. So let's go ahead. What did you do?
Dr. Gaurav? Okay. Is he having some network issues? Dr. Gaurav?
I think we can the next one.
Okay, we can take the next case on. Dr. Anil, can you share your screen?
Gaurav is back. Let's see if we can connect that.
Dr. Gaurav, can you share your screen, please? So would you change your entry point for the femur if you are using the EM rod? There was some discussion and a few papers on the same as well.
Gaurav's not there, so what should I do? Should I proceed?
Yeah, let's see if he comes back, then we'll get him to put up his X-rays.
Slides, yeah.
Okay.
So to answer Anoop's question, there you can use either a short intramedullary rod because it's about halfway up the canal, but you will still have to measure the VCA. The VCA is quite substantial here.
Substantial.
It's massive. So I don't think you'll really be able to cut the femur at 10 degrees or 15 degrees of valgus relative to the lateral femoral condyle. It'll be a massive angle. So you're going to have a huge lateral gap to correct medially.
Right.
So it doesn't make sense. It's far more sensible to do an extra-articular correction and minimize the problems that you face. Yeah, Gaurav is back. What did you do?
So 1 minute, I just share my screen.
Gaurav, click on share screen and then click desktop, the first one.
Yeah.
Yes, now you can see. Play.
Yeah. I use eye assist. I just use eye assist and I went ahead with the TKR. So this was my alignment on the X-rays, AP and lateral view. So this is why I got in post-op scanogram.
It's pretty good.
Yeah.
So what did you end up releasing?
On medial side, I just routine release. I didn't release any MCL or something like that. Just routine posterior medial release, and with the I didn't have to do much struggle for the knee. But only worrisome thing is for me, if you see the post-op scanogram, so the tibial component on the left side I think is not parallel to the ground. So it's slightly in some. So is that thing I have to worry in the future?
So how's the patient doing? That is the key question.
Now the patient is doing very well. It's today's X-ray only. It's today's video only. It's post-op 3.5 years. Walking comfortably.
Yeah, so this is very good. So I would not worry too much. If you've not done any major release and it was fairly correctable, then this is an outstanding result. This is very good.
So in case of any limb length shortening, do we correct it or what? We leave it? This is 1 centimeter shortening on the left side.
Yeah, but that's part of the trauma that occurred, right? That's the malunion. So she does have a little limp. So you should give her a shoe raise. That's the easiest solution. Give her a shoe raise.
Yeah.
And what you need to see besides the gait is actually whether she's opening up medially, because on the X-ray it looks as if the medial gap is a bit more.
Okay.
If you see, but there aren't any AP X-rays. Yeah. But it just appears as if there's a bit more opening up medially. I'm not sure. Not in this X-ray, but on the standing film. These are supine. Yeah. But here it just seems to be. But otherwise it looks pretty good. Okay. The only question is the fact that you're going into slight valgus, a minimal amount of valgus on the tibia and on the femur. I'm just a little worried what you've done on the medial side in terms of the soft tissues.
Mm-hmm.
But I can see some sort of a bony flake near the medial epicondyle. So whether it's an inadvertent medial slide that has occurred. Can you see the bone fragment there?
Yeah.
So I'm just wondering whether a more formal medial epicondyle osteotomy would have been a better choice.
Okay.
But some sort of inadvertent osteotomy may have occurred because you see that bone fragment there near the epicondyle.
Okay.
On the medial side. Can you see it?
Yeah.
Yeah. So it's quite likely because if you look at the adductor tubercle and you look at the medial femoral condyle of the femoral component, it's far greater than on the right knee. So you put the femur in a substantial amount of valgus.
Okay.
So obviously the only way this can happen is if the MCL has somehow come off medially, either in terms of soft tissue or with a flake of bone, and has gone on to heal. because now it's nice and stable.
Okay.
At least from a gait point of view. Whether when you check it in flexion extension, you'll know how stable it is. But I suspect that there would be some inadvertent release of the medial collateral for you to have accommodated this femoral component in this position. But otherwise, good result.
What was the rotation like? Especially you talked about the torsional malunion as well. What was the rotation that you had to give for this case?
It is a proper 3-degree rotation. I use eye assist, but it was kept.
Eye assist will.
It was kept in 3-degree rotation.
Rotation. Okay.
Yeah.
Okay.
Normal. I assist just for the
distal cuts. Yeah.
All right. Pretty
okay,
good.
Nice outcome. Yeah. Can we go on to the next case? Dr. Anil, can you share your case, please?
Yeah. Once this screen is closed. Yeah.
Yeah.
Can you see the screen?
Yep.
Yeah, we can.
I would like to thank the conveners of this OrthoTV and Young Surgeons Forum at the outset for giving me this opportunity. And thank you, Mullaji sir, for mentoring us through this session. I've prepared this case as more for young surgeons rather than discussion with you, sir. So I've just put it as a tips and tricks for the surgeons. So to start with, this was in my initial days of practice around 2014, something like that. It's a 55-year-old gentleman who presented to me with severe varus and flexion deformity. This is how he presented to me. He was walking with so much of varus thrust, difficulty in activities of daily life. He had this pain for more than 3 to 4 years, but I don't know how Indians manage with this kind of deformities before they come to us. This is how he presented to me. This was this X-ray. At that time, I did not have access to get full-length X-rays. So this was the both knees AP X-ray, which shows significant medial bone defect with some laxity on the lateral side. And this is both knees lateral views showing significant osteophytosis on the posterior aspect of the tibiofemoral joint as well as the patellofemoral joint. So before going ahead, I just wanted to discuss what to consider in these sort of cases, whether we do bilateral or unilateral. Normally, I am comfortable doing one knee at a time and then giving some time before doing the second knee. But in this kind of severe deformities, I plan to do both knees together to avoid excess stress on the operated knee because of the deformity on the opposite side. So I went ahead and did a...
Just one minute. I'd like to stop you there.
Yeah, yes, sir.
Before you reach this point, there are a couple of things you need to, I'd like to suggest.
Yeah.
Yes, you didn't have a scanogram, but you can always do an oblique, you can take a long film and do the femur on that. Okay, place diagonally your plate and get a full length femur.
Yes, sir.
And the same thing you can do of the tibia. So even if you don't have a full length standing X-ray, at least you can make out whether there is any extra-articular deformity on the femur or tibia. So that's not really an excuse that you don't have scanogram, but at least you can get the anatomy of the femur, appreciated before you operate. Secondly,
yes, sir.
When you see such an X-ray with massive loose bodies, so much of bone loss, lots of fragments of bone, calcification, and a person who's walking reasonably comfortably, you should do a thorough neurological examination to make sure that this patient does not have a neuropathic joint.
Yes.
So these are two very important things that you should do, is a proper assessment of the X-ray and secondly of the patient before you start talking about whether you should do bilateral, etc. I think there are two important things. The assessment of the patient is very important. Okay, go ahead.
Yes, sir. The excuse is not that there was no scanogram. At that time, I was not doing scanograms as well, sir. That was my mistake, sir. Not lack of availability of the X-rays as well. Yeah, but later I tried to develop that habit, sir. Yeah, and neurologically he was fine, sir. I didn't put it in the history, but neurologically he was fine. He didn't have any other problems. The other joints as well was normal, sir.
Okay.
So then I did a bilateral staggered knee replacement for this patient. And the other considerations were what kind of implant. Any primary implant would be good, but probably would have a backup of next degree of constraint with extension rods in case of the significant bone defects or the increased size of the polyethylene to balance the knee.
Yes, sir, I'd like to just stop you there.
Yes, sir.
There are two separate issues. One is bone loss requires a better fixation.
Yes, sir.
Second, that bone loss has nothing to do with constraint.
Yeah.
Okay. It's the other way around. If you add constraint, then you need to increase the fixation strength in the bone also.
Yes,
but
sir.
not the other way around. If you increase the fixation to the bone, because there's bone loss, doesn't mean you have to also increase constraint. Constraint is governed by stability and soft tissue balancing.
I meant the reverse, sir. I meant if we have put a thicker poly, then to reduce the torque on the bone cement interface, I said we could add an extension rod in those kind of thicker polys. I mean, more than 15 or 15 size. That's what I meant, sir.
Okay, go ahead.
Yeah. Then surgical approach, I routinely do subvastus approach, but in these kinds of cases, I'm okay doing a mid-vastus or medial parapatellar approach, depending upon the patellar mobility before the surgery as well, sir. Then the surgical technique, normally we either do measured resection or gap balancing, but in these kind of cases, I believe we end up mixing both together. We might start with measured resection, but most of the times we have to do the gap balancing as well to go ahead.
I think you should not even talk about measured resection when there's so much of defect, because the moment you take out 9 mm or 10 mm from the tibia, you're not going to have an insert thickness available to you. If you took out 9 from the tibia and 9 from the femur, you're going to be in deep trouble.
Yes,
so I think measured resection really is not a good idea.
So, the problems expected in this kind of cases were medial capsular contracture and lateral laxity, and the femoral rotation due to posterior medial femoral condyle hypertrophy into the bone defect, and then tibial defect bone management, and then flexion extension gap mismatching, and patellar tracking due to internal rotation because of the altered posterior condylar axis in case of posteromedial femoral hypertrophy. These are the routine surgical steps. I just put it as a stepwise manner for the younger surgeons. Initially, we go through medial release till the mid-coronal plane of the deep MCL, not the superficial MCL. Then osteophyte removal on the femur, patella, as well as tibia anteromedial surface. Then distal femoral cut. I generally take a minimum distal femoral cut possible in this kind of excessive deformities, and then try to do the tibial subluxation, which can be different in such deformities because of the significant posteromedial osteophytes in the tibia. Sometimes removing the osteophytes before subluxating the tibia will help. I generally try to osteotomize the posteromedial corner of the tibia so that it helps in the subluxation of the tibia anteriorly. Then I take a minimum tibial cut around 6 to 8 mm on the lateral side. After that, I try to size the tibia and do the medial reduction osteotomy if medially it is very tight. If extension gap is well balanced, I don't do it at this stage. But if extension gap is very tight, Then I'll try to balance the extension gap by doing medial reduction tibial osteotomy. Then after that, I'll try to do the femoral rotation and sizing. Femoral rotation and sizing, I base it on tibial surface here instead of going directly based on the posterior femoral condylar axis, which might be altered due to the posteromedial hypertrophy of the femoral condyle. So I'll try to go parallel to the tibial surface in 90 degrees of flexion in these cases. Then I'll do the trial implantation and assess the tibial defect and try to reconstruct it. This, I've just put a short video of the medial reduction osteotomy, but Dr. Mullaji sir has already demonstrated it, so I'll skip through it, sir. Then tibial bone defect management in these patients, lateralization of the tibia. Then medial defect can be filled with screws or cement if it is very small, less than 30% of the defect. But if it less than 30% of the undersurface of the tibia, if it is more than 30% of the undersurface of tibia, then we might have to reconstruct with the bone graft or augments. And I use extension rods if there is less than more than 30% of the defect on the tibial undersurface. This is what I did. I did bilateral cruciate sacrificing knee. This is Columbus knee. I did augment the medial defect on both sides with the screws and cement scaffold. And on the left side, which I did later, I had to use a stem because of the lesser contact area on the undersurface of the tibia compared to the right side. This is how the patient was doing around the second day after the surgery.
You had done them staggered, right?
I did staggered, sir.
How many days apart?
4 days apart, sir.
Okay. Generally speaking, that's not a good idea.
7 days.
You either do them together or you should do them 3 months later.
Yes, sir. Normally, I don't do bilateral at all, sir. In the deformity only, I did, sir.
But I mean, sometimes you may run into a problem if you do it within a week of the first surgery, because in terms of the physiology, there are a lot of acute phase reactants, cytokines, etc., higher risk of DVT, PE. So complications are much higher if you do it in that.
Yes, sir. I don't do any staggered knees now, sir. After going through the literature and the complications in the initial phase, now I don't only do staged or simultaneous, sir. At that time, I was not very comfortable doing simultaneous bilateral at all, sir.
No problem, but I just thought I'll make that point for the other people.
Yeah, yes, sir. Yeah.
This is a very good result.
Yeah.
Looks great. Yeah.
And it is around 7 years now, sir. I couldn't get a present video because he's in a village and he couldn't send me the video today. But yeah, he's doing good now, sir. 7 years down the line, he's doing good, sir.
Excellent. Thank you. And shall we go to the last speaker? Because I think we are really running out of time.
Yes, sir.
We have one more person.
Yeah, I'll
yes, sir, Dr.
sharing, sir. Thank you.
If you
can you stop sharing, Dr. Reddy? Yeah.
Yeah, I did. Thank you.
Punit, are you showing your case?
Yes, sir. Yes, sir. Good evening, sir. I would like to thank the Young Surgeon Forum and especially Dr. Mullaji, sir, for being here. My case is a TKR in severe varus deformity with a tibial defect. Sir, can you hear me?
Yeah, go
we can.
Yeah. So my patient is a 71 years old male with a BMI of say 26 around. No comorbidities, like only hypertensive. Difficulty in walking since more than 5 years, and walking with a brace and with the help of walker since last 3-4 years, and mainly homebound only. On clinical examination, there was no effusion, minimal patellofemoral pain. Range of motion was around right-sided 5 degrees, both sided 5 degrees FFD, and a flexion of around 120 to 130 degrees. But he had a significant amount of varus, right-sided 25 degrees and left-sided around 20 degrees. But both were like correctable varus. Both the sided hips were normal and there was no neurodeficit. These are the preoperative X-rays showing right more than left osteoarthritis, and mainly right-sided with a significant stretch out of LCL and significant osteophyte seen on anterior as well as posterior aspect of on both the sides. Sir, again, sorry, actually I don't have scanogram with me. These are the pre-op clinical pics showing varus and which is correctable to almost 5 degrees. This is the video. The femur is going into that tibial defect and giving rise to so much amount of varus, and but it is correctable with a good range of movement. Sir, my plan was a routine mid-vastus approach and medial and posteromedial release with PCL sacrificing knee, removal of the medial femoral osteophytes underneath the MCL, followed by reduction osteotomy on the medial side of the tibial condyle, deep MCL release, and if required, MCL pie crusting, as I asked you about the same. Implants I kept ready like bone graft from the condyles, which distal femoral cut to fix with the screws. I kept ready with the 4.5 mm screws. I was using a PS knee of Depew, kept stems as a standby as well as constrained knee and wedges. Intraoperatively, there was complete loss of cartilage, as we can see on the X-ray itself. A medial femoral condyle as well as medial tibial condyle, and there was a significant defect on the medial tibial side. Steps I do the femur first, distal femoral cut. I took the standard 9 mm cut with the intramedullary jig, and posterior proximal tibial cut with an extramedullary jig, but it was lateral side. I took only 6 mm. PCL was taken out. With anterior referencing, I initially did the posterior femoral cut only, not committed with the whole femur. And then, as I said, complete medial and posteromedial release, all taken out the osteophytes, full posterior release, followed by then in extension, it was not balanced. Lateral opening was there. My even 9 mm spacer was not going in, especially medial side. So then I did the tibia. I went on the tibia and medial tibial reduction osteotomy I started. And then the extension gap got balanced. After that, I did the full femur, and after checking my flexion gap. After doing this balancing part, there was a significant defect. Then I take the lateral side of the distal femoral cut, took out the cartilaginous part of that area and put it over the medial femoral condyle, medial tibial condylar defect. Fixed initially with the K-wire, followed by 2 screws. Took out the extra part. Similarly, there was some uncontained defect on the lateral side, which was filled with the cancellous bone and impacted. The rest of the underneath area of the tibial condyle, tibial component was filled with the cement. And this is my post-op X-ray. I added the extension rod to it.
Looks very good. I'm just wondering whether you needed such a long stem.
Sir, actually, I didn't have that stubby stem available. This was the only stem to start with.
Okay, because that's a bit too long, I guess.
Yes, sir.
Then you're stress shielding, you're causing end of stem pain. So the longer the stem, the worse it is. So a little shorter stem might do well, but otherwise I think it's come out very well.
Yeah.
Doing?
Sir, he's doing well. I did the other side as well. After a gap of 2 weeks, left-sided, almost same picture, same medial tibial condylar defect with some uncontained contained defect as well. Similarly, did this side also. and ended up with doing this side.
Yep, looks very good. So just be careful doing all these at 1 and 2 week intervals, because you might get away with it, but sometimes you might have a problem, infection, DVT, P, all these things, that 2 week period, that initial post-op period with the acute phase reactants is a little risky.
Sure.
All right.
Sir,
Great.
actually, I wanted to ask this question on right side. This gap looks more than the medial side. Intra-op, I had a stable knee. So this should be a point of worry, and what could be the reason for this? Means, is it more of a valgus? I put the femoral component in little valgus, or is it the lateral opening more than the medial?
So this is what is called imbalance.
Sir.
So this is a supine film. So you will really know the extent of imbalance only if you give a varus stress. In 30 degrees of flexion, if you give a varus stress, then you will be able to say whether this is stable or not. But when in a supine film you see more than 2 millimeters of difference on the two sides, it's clearly imbalanced. Okay. So what will happen in the future, we don't really know. You have undercorrected the alignment slightly. It's a little bit in varus overall. If you take a long film, it might look like it's slightly in varus. Luckily, you've got a long stem on the tibia, so chances of any tibial failure are very minimal. But over a period of time, you may have polywear, but it's only time will tell. What will be the effect of instability, whether the patient will complain of pain or stretching on the lateral side because he's got a little adductor thrust when he walks. So all that we'll know only if you have full-length films and some gait studies.
Okay. Sir, what is your technique of putting a graft in the tibial defect?
So almost in 2007, we had published a paper on these severe deformities in JOA, and there we have shown we create a step cut defect and use the intercondylar bone to fill that defect. The intercondylar notch, that's a fairly large chunk when you're doing a PS knee. So you can use that to fill the defect on the medial side. So we create a step cut defect, and most of the times you'll require a long stem, and we fix it with 1 or 2 K wires, if required a couple of screws, but I put them horizontally.
Okay.
But you can do it whichever way you want. So we've described this in the Journal of Arthroplasty, how to bone graft. But this looks good. Only thing is the stability is something that we'll know only with some more dynamic evaluations.
Sir, does that lateral laxity be okay if the mechanical alignment is more on the lateral compartment than the medial compartment, sir?
So laterally, if it keeps opening up, this person will have a little bit of a waddling gait, like an adductor thrust type of gait.
That is if the mechanical alignment is more on the medial compartment, right, sir? If it is corrected and still there is a lateral compartment laxity. I mean, if the weight bearing axis or mechanical alignment is more going through the lateral half of the tibia, lateral tibial eminence, is this laxity okay in those cases, sir?
I'm not sure that you'll be able to achieve that situation.
Okay.
I'm not sure how you'll achieve it, because the only way you'll be able to put it where the weight bearing occurs laterally is if you put the femoral component in a little more of
valgus. Femoral component in valgus and tibial component in varus, sir.
Yes.
So
that combination might work.
That combination. In this case, it is tibial.
Tibia is in valgus and femur is not in valgus. It's in slight minimal varus. Okay. So therefore, it is actually going into varus.
Yeah, it's medial tightness and lateral laxity, so it might progress. That's what you. Okay.
That's my worry, that over a period of time, the instability may increase.
Okay.
Okay.
But that's something that only if we see some varus valgus stress views, then you'll know how much it's opening up. And also, if these people strengthen their IT band, you might be able to help them.
Okay, sir.
To somewhat compensate for this laxity. The iliotibial band, IT, the lateral structures, you need to strengthen them.
Okay.
So sometimes, if at all we are having some kind of tightness in spite of the release, reduction, osteotomy, so it is clearly, we don't have a clear balance. Sometimes it helps to put in a stem so that the tibial tray does not book.
Yeah, but the other thing he could have done here was a bigger reduction osteotomy. This tibia could have been undersized a little more, and that would have given him 2-3 millimeters, and that would have probably helped him to align it even better.
So, and sometimes it's only the flexion medial compartment is tight. In extension, you're having possibly a good balance or possibly a little loose on the medial side as well. I mean, the insert goes in extension, but when you flex it, you're having booking. So you release a posterior capsule, you do whatever release of the MCL that you have, but it's only the flexion, the medial compartment is tight. And that's where the insert actually books. So in that case, would you actually do a sliding osteotomy? What would be your take? How do you balance in that situation? Would you increase the rotation? Now he is committed to a 4-in-1 cut as well for the femur.
Yeah, easiest solution would be to increase the tibial flexion, posterior slope of the tibia.
That's right.
That'll give you a little more flexion gap.
But sir, it is tight only on medial side. Then
you will have to do external rotation of the femur or epicondylar posterior slide, probably.
So here, I think a reduction osteotomy could have been a larger reduction osteotomy. You could probably have downsized the tibia, and that would have given you enough leeway and correction of the imbalance.
Right, sir.
The other thing that's happening is you put the tibia in valgus, so that also has opened up the lateral compartment a little more. So the lateral joint space has increased because you've gone into valgus. Had the tibia been in varus, slight varus, you would have been better off in terms of the instability part. So,
but looking at he has put in a long stem, possibly that has helped to get in, the alignment. He can't correct that now. If you use a long stem.
Correct. So
it is out of his control.
This is now, at this point in time, there's nothing you can do. But I'm just saying during your trial reduction, etc., if you find that it's too tight in flexion, then you can increase the slope slightly, because
that's right.
If you see his lateral X-ray, his slope is probably 90, or maybe one or 2 degrees of slope only.
Yeah,
that's right.
So it's minimal. It's probably 2 degree slope, because when you put in a long stem, that's a 2-degree angle with the tray.
So if you are stuck at this situation, what would you do? A medial slide, 4-in-1 done, tight in flexion. You can't do a reduction osteotomy because your medial tray, in spite of lateralizing, is still you can't do a further reduction. What would you do, sir?
If it was still tight medially?
Yeah, a slide osteotomy or increases the slope?
I'll increase the slope a bit.
Right.
All right.
Sir.
Right, sir.
So any further queries, or shall we call it?
I think we can call it an inning.
Yeah, I think it's been a long innings. So
thank you very much, sir, for spending
very good cases. You all have done a good job. You all are doing a good job in arthroplasty. I think the future of Indian arthroplasty is safe in your hands. That's good. So keep it up, but do a little more in terms of pre-op planning, proper assessment, measurements, and try and look at your post-op X-rays with full-length films. Analyze them in more detail, because that's the only way you'll keep getting better.
Yes,
all right.
Yes, sir. Thank you.
Thank you, sir.
Thank you so much,
Thank
sir.
Thank you.
Really appreciate your presence and your time, sir. Thank you so much.
Okay, take care. Bye. All the best.
Thanks, sir. Bye-bye. Good night, sir. Bye-bye, sir. Thank you. All, I guess, fabulous cases, yeah. Wonderful outcomes.
Yeah, thank you for inviting me.
Nice outcomes.
And Anoop, thank you.
Anoop, sir.
Thank you, Anoop and
Great,
Jay.
great.
Thank you.
Yeah, thanks. Yeah, sure to meet you again. Bye. Take care.
Bye. Good night.
Bye. Good night.